was fantastic.
You're welcome.
So how many people were there for the high performance CPR lecture? So a handful. So this is sort of the next one on kind of what do we do when the resuscitation ends. And this has been sort of, I think, a really successful journey. People have been in the system a long time. Chad, how many years have you been working? When did you start?
In this system?
Yeah.
It's been 13, 14 years.
Okay,
now.
so
yeah.
when I started here, we transported a lot of cardiac arrests, and then we really shifted a focus to resuscitate on scene and encourage termination resuscitation. And back like 14 years ago, I think we were transporting something like 80% of patients in cardiac arrest to the ER, and now we're transporting something on the order of like 4 or 5%, really low, a handful a year. And a lot of these are for reasons like narrow complex PEA with great end tidal, maybe something to be done at the hospital for this patient, or they're in a public environment. I don't want to leave them in the middle of the aisle at Hannaford's or something like that. So we've come a long way, and it was a huge culture change. But what was a huge challenge for this is how many of you, and it's getting better in EMS, but who's had training in delivering bad news, breaking bad news? So I see a handful of hands go up. I can tell you that, like, I never got formal training in this until medical school. So it's just not something that's in a lot of EMS curriculums. I think it is now. So it was sort of unfair at the time to say, hey, you got to resuscitate these people on scene. And by the way, when you determine that they're dead, like, just deal with that. Deal with families and stuff. So I want to really focus on this concept of how do we deliver bad news. I do want to recognize a few people. So most of this talk is from Doug Kupas, who's at the Geisinger Medical Center, former state medical director of Pennsylvania. Tom Dix, the guy who writes for CCEMS. And then Eric Yeagers from New Hampshire. He's got great information on his website, True North Group, on delivering bad news. And then Alexander Jabbar is like I think she's out of Kansas City. She just has some great online. If you find her website, you can actually pay for a course on this. Her PhD is in does a lot of stuff around communication death notification. So all good resources. So we're going to talk about review family presence and our kind of local New Hampshire protocols. We'll discuss the grief reaction, the do's and don'ts of death notification, and I hate mnemonics, but I'm going to go through this grieving mnemonic because I think it kind of covers all the nuts and bolts of what we do. All right, so everybody dies, right? They always have, they always will. And the key thing is survivors really view death in numerous ways. I can tell you that I have no death notifications are created equal. They're all a little bit different. Life is a fatal condition with 100% mortality. And I like this one was from Eric's website. It's a part of life, and it's really our responsibility to tell patients and their families the truth with empathy and compassion. Even when the truth is hard to hear or sometimes hard to say. I think this is a real important thing. So this is a difficult task for healthcare providers. It's a skill, right? It's not, I have seen people do a shitty job at this all of my career, and I've seen people who are just amazing at this, and I've really tried to emulate the ones that I thought had that sort of compassion and really did a nice job. And some people just are really bad at this, but there are some tools you can use to make it better. It's one of the most stressful life events for the survivors, and they're going to remember it. So the first question is, should family be present during resuscitation? What do you think? Anybody have good experiences with family being present during resuscitation? I see some nodding. Anybody have bad experiences? Nodding. So it depends, right? It depends how they're going to react. So I think that for the most part, most family members can be present when they're offered and they don't cause a problem. I have had issues where you have to have somebody moved out of a room or move the patient out of a room because patients or families are being just, I don't want to use the word crazy, but being really pretty unusual. But most family members I find that are fine being there. And this has been looked at in a lot of studies. Most family members, they want to be there, and they make the decision to do it again. Patients' families really feel like it's their right to be there. It's their family member, and they feel it's both helpful to them and their families for being there as well. It gives them sort of a sense of closure. And concerns of having it be disruptive or traumatic, usually that's not the case. And there's really no evidence to support that there's litigation happening because of this. And this has been looked at Big study, fairly big study, 570 family members. They were randomly assigned to be offered family presence versus the standard protocol, which was sort of like leaving out rooms just in an ER setting. And really they found that family presence during CPR was associated with positive results of these psychological variables, did not interfere with medical efforts, didn't really increase the stress of the healthcare team or result in medical legal conflicts. I also think, for me, it actually makes death notification easier if family is there often, because you're sort of telling them slowly that their family member is not doing well and they're dying or they're dead throughout the process, as opposed to, I think of in the ER, it's the worst feeling in the world when somebody comes in, we terminate resuscitation, oh, patient spouse is in the family room and I have to go knock on a door and kind of go in and start from scratch. If they're there and they're appropriate and you're kind of telling the story and they're helping kind of sometimes make that termination resuscitation decision with you if you have a great family member. And feel free, if you have experiences with this stuff, jump in, because I think anecdotes are important with this because we see all sorts of stuff. So termination resuscitation. Why do we do it? We talked a lot about this. Interrupting chest compression is harmful. CPR and moving ambulance is shown to be ineffective. Could be a little dangerous too if you're not belted in. And patients not resuscitated. I think the most important, resuscitate in the field, like, you're not going to make it generally. You're going to be dead. So we should work, and we are the experts in resuscitation in the pre-hospital setting. So just really quick going over the New Hampshire protocol here. There's going to be some changes to this coming up, I think. I think it's mostly formatting changes, but basically, obviously you can stop if your environment is unsafe, like don't put yourself at risk, right? If there's something going on. You're physically exhausted. This is one that's really controversial here. We don't really know what to do with. If you don't have a paramedic and the AED says no shock for 20 minutes and hospital care or a paramedic is not available in 20 minutes and the end tidal is less than 20, you can stop. Extrication is prolonged without being able to do chest compressions if they're not hypothermic, and directed use of medical control. In most of these situations, I would say to call medical control if you're a medic and you're just getting that no shock advised just to cover your bases, because you really know what we're in. For the paramedics, we kind of divide this of asystole or slow wide complex PEA. These are the patients that probably aren't going to do very well. If there's no return to spontaneous circulation after 20 minutes and end tidal is less than 20, you can always call medical control. If you have an end tidal of 30 and you have somebody in asystole for 20 minutes, they're probably not going to do well regardless. And then narrow complex PEA with a rate above 40 or refractory VFib, VTAC. You can consider resuscitation up to 60 minutes from time of dispatch, and don't think like, oh my gosh, you're in PEA and or you're in VFib and I'm going to work you for 60 minutes. Oh, and by the way, you're 95 years old. I mean, I think you can this is where the nuances, right? There's frailty, there's comorbidities, so there's lots of things that you're going to say, why are we doing this to this 85-year-old frail person, or this person who's got a history of renal failure and metastatic cancer, or whatever it might be. A lot of times you can use medical control for guidance and also family for guidance, right? Does your husband want this? Would he want us to continue doing this? You can use that, and feel free to call medical control if it's a situation like that. If you don't have to do 60 minutes, but the 55-year-old who has a witnessed cardiac arrest and a shockable rhythm that's bystander witness and bystander CPR and remains in a good course VFib, boy, that's a patient I might work up to an hour, because there are survivors, and we've had them in our community. We've had some of the survivors.